Good afternoon and welcome, everybody. Thank you for joining us for insights from the LDS Natural History Study at NIH. We're going to be focusing on audiology and otology today. My name is Stacy Watson. I'm the director of Loeys-Dietz and Marfan at the Marfan Foundation, and I also live with Loeys-Dietz Syndrome type 2, and I have participated in this natural history study at the National Institutes of Health. And participating in the study has been very affirming for me. It meant a lot to contribute to the research that supports our community. And I'll share more at the end about how you can learn more if you are interested. We are honored to be joined today by Dr. Jeffrey Kim, a neurootologist, and Julie Christensen, audiologist, who will walk us through key findings. Just a quick note before we begin. This webinar is being recorded and the replay will be shared on our YouTube channel, and all who are registered and attending will receive an email with a link to an evaluation as well as the recording itself. Please use the Q&A feature in the webinar so that we can keep track of any questions. We will have time at the end to answer as many as we can. And with that, I'm going to turn it over to our speakers. Thank you for being here.
Okay, great. This is Jeff Kim. I'm going to start first. And I just want to first thank Marfan Foundation for allowing Dr. Christensen and I to present this afternoon. And we'll be talking to you about the audiologic and otologic clinical manifestation of Loeys-Dietz syndrome. Okay, next slide. Okay, so as many of you know, LDS is a rare genetically heterogeneous condition, typically inherited in autosomal dominant manner. And there are currently 6 recognized subtypes so far, defined by the mutations of different genes in the TGF-beta signaling pathway, also known as the transforming growth factor beta signaling pathway. And this pathway is known to control collagen production, tissue repair, the vascular wall integrity, and craniofacial development. And classically, LDS is characterized by craniofacial abnormalities, which I talk about a little later, arterial and aneurysm and dissection at early age, and tissue and the soft tissue changes. As I mentioned, there are 6 subtypes out there. As I mentioned, there are 6 subtypes out there. 1 and 2 types are typically characterized by classic craniofacial and the vascular features. And type 3 is characterized by early onset arthritis. And type 4 and 5 are usually present with the milder symptoms and typically diagnosed at a later age. And then type 6 has additional congenital heart condition to it. So next, Dr. Christensen will talk to you about how ear works and how we evaluate for hearing loss.
Everybody, it's really nice to be here. Thank you for coming. So I'll briefly walk everyone through the auditory system and how it relates to hearing, how hearing loss relates to it. This is an audiogram. I'm sure a lot of you have seen this before. It's a graphic representation of your hearing. Sorry, guys, I'm just trying to get situated with how I'm going to advance the slides. Sorry, Jeff, I'm just going to go in and hit my little cursor here. Okay, so this is a graphic representation of your hearing. Across the top are low pitches out to high pitches. It's all the frequencies that you need to be able to hear to understand speech. And on the side are soft sounds at the top down to loud sounds. And these marks in the middle, the red circles and the blue X's, indicate the softest sounds that a person can hear at each of these different speech frequencies. The red circles are the right ear, and the blue X's are the left ear. And you can see in this picture that in this case, the left ear is better than the right ear. Thank you. I'll hit it from here. If those lines had fallen into this green range, then that hearing would be normal. From there, there are different degrees of hearing loss. The first is mild hearing loss, moderate hearing loss, When sounds have to be louder to be heard, it becomes severe hearing loss, and then finally profound. And you can see with this person's hearing, the left ear is completely a mild hearing loss, but in the right ear, the hearing begins as mild in the lowest frequency, 250 hertz. It drops down to a moderate loss in the mid frequencies, and some of the mid frequencies are also in the severe range. And then in the highest frequency, it drops down to a profound loss. And the highest frequency we're talking about here is 8,000 hertz. And I say that because I'll be referencing that again in a couple of minutes. So these are the degrees of hearing loss that we'll be talking about: mild, moderate, severe, and profound. And there are 3 types of hearing loss: conductive hearing loss, mixed hearing loss, and sensory neural hearing loss. So we're back to another audiogram. This is a different set of ears with a different type of hearing loss. But when we look at this, this is air conduction thresholds. And what that means is that we have headphones on your ears, and when we make our measure, the sound goes through 3 parts of your ear. Your ear is made up of 3 sections: the outer ear, the middle ear, and the inner ear. And so a sound comes through the air and it's captured by your ear. It goes right through your ear canal, the green section, to your eardrum, which is at the end, and it sets that eardrum vibrating. And that vibration then travels through the middle ear, the red area, carried by these 3 little bones called the ossicles, or you might hear, we also will say, ossicular chain in this presentation. So the sound vibrates through this ossicular chain of 3 little bones and reaches the inner ear, which is that snail-shaped piece, which is also called the cochlea. And the cochlea is filled with fluid, and it has a very thin membrane in it that curls up through this snail-shaped part of the ear. And that vibration sets that membrane moving, and that causes hair cells in the inner ear to shear and convert that mechanical energy, that vibration, into a sorry, I'm missing my notes. I want to make sure I don't miss anything. Into an electrical signal that travels up the auditory nerve, or here it says the cochlear nerve, to the auditory cortex of your brain. So when we have this measure, which is what's represented by these X's and circles on the audiogram, all we know is that this person has a hearing loss, but we don't know what part of the ear is impeding the sound from reaching the brain. It could be in the outer ear. Maybe there's a cholesteatoma there. It could be something in the middle ear like fluid, or it could be damage in the hair cells of the inner ear. And so to understand which of these things is happening, we do bone conduction. And you can see the bone conduction piece on this little girl, this black thing. We just sit that on the back of the skull behind the ear. It sits on the temporal bone, and it vibrates those same beeps, those tones, those pure tones, straight directly to the cochlea, the inner ear. It bypasses the middle ear and the outer ear. And when we do that in this particular person, when we graph what we got when we just tested with bone conduction, you can see it's represented by brackets, red brackets for the right ear and blue brackets for the left ear, that these are all completely in the normal range. So the cochlea is doing its job. It's doing a really good job of bringing sound up to the auditory cortex of the brain, but something in either the outer ear or the middle ear is impeding the softest sounds from getting there. We would call this a conductive hearing loss. And you can see this figure on the left is that same exact hearing loss. And conductive hearing loss is defined as hearing loss from air conduction with normal bone conduction thresholds. The next figure over is sensory neural hearing loss. And in this case, the air conduction and bone conduction are interlaid on top of each other. There's no gap between them. So we know in this case that all of the loss is coming from the cochlea or the auditory nerve going up to the brain. It's not caused by anything in the middle ear or the outer ear. And then the last figure shows a mixed hearing loss. And this is a little bit of both. So the bone conduction shows us that the cochlea is not operating to send the softest sounds up to the brain. But on top of that, there's something happening in either the middle or outer ear. Maybe there's fluid too. So they have what we would call a sensory neural hearing loss, but they also have fluid further impeding the sound, and that's called a mixed hearing loss. Hearing loss by bone and air, but with air-bone gap, a gap between the air and the bone. And I'm also going to point out, you can see by the circle up here that we cannot measure bone conduction at 6,000 and 8,000 hertz. And that's important to remember, because if somebody has normal hearing except at 6,000 and 8,000 hertz, we can't define what type of hearing loss they have, because we need bone conduction to be able to do that. And now I'm going to send it back to Jeff.
Okay, great. So now that we understand the basic anatomy of an ear and types of hearing loss, I'm going to talk to you about the craniofacial features that we saw in LDS, and then how that get related to or result in a hearing loss. So we previously looked at the 36 patients in LDS, and we previously presented and published in 2022. Since that time, from 2018 to 2026, we have seen 42 additional patients, mostly LDS 4, 5, and 6. However, as you notice, that majority of our patients in our cohort still LDS type 1 and 2. And this patient tends to be more younger than 4, 5, and 6, as they usually get diagnosed early age due to their classic craniofacial and vascular findings. And because we only have one patient in LDS 6, we exclude that person in our analysis. So as you can see on this slide, and most of you are familiar with it, craniofacial features associated with LDS are facial asymmetry, blue sclera. When you have a wide eyes apart, we call it hypertelorism. If you also have a, sorry about that, and then they also have a various palate and ear anomalies such as a cleft palate, bifid uvula, and high arch palate as well. As shown in this table here, the most common craniofacial feature that we see is facial asymmetry, followed by hypertelorism and blue sclera. One of the hallmark that distinguishes LDS from the Marfan syndrome is palate anomalies. Most common palate anomaly we saw was the high arch palate, which account for the 58% in our cohort patients, and then bifid or split uvula was found in about 23% in our cohort. In contrast, high arch palate was the least common in type 3, and some of our patients did undergo palate surgery as in type 1, 2, and 5. Eustachian tube, as pointed out by the blue arrow, is the tube that connects between the middle ear space and the back of the nose. And its function is to equalize the middle ear pressure. If the palate in the back of the mouth is not well formed, it resulted in eustachian tube dysfunction, and this can lead to, sorry, it's automatically advancing. I'm not sure why, but anyway, sorry about that. But anyway, so if you have eustachian tube dysfunction, this can result in recurrent frequent ear infection, accumulation of middle ear fluid, as well as the ear pain associated with the change in pressure as when you are when you're flying. So in our cohort, 42% of our patients had a history of recurrent otitis media or ear infections, and in type 1 and 2, approximately 25% actually had an ear tube placement to prevent the recurrent ear infection and drain the middle ear fluid. And often this will result in tympanic membrane perforation and the hearing loss, as you could see on the picture. So the picture on the right, you can see the middle ear fluid. It was the yellow fluid. This is the ear tube placement that we use to drain the fluid out. And then sometimes after ear tube comes out, it results in tympanic membrane perforation, as is shown in this slides. And if you look at those people who had ventilation tube placement, many of them actually had the palatal anomalies or surgeries. So 5 out of 6 in LDS1, and then 5 out of 7, and then 1 out of 1 in LDS5 actually had a bifield uvula or palatal surgery or cleft palate. And then in our patients, approximately about 25%, sorry about that, 25% to 28% of LDS1, or the 50 to 43% of ears end up with a tympanic membrane perforation after ear tube extruded. Typically, once the ear tube comes out, the eardrum closes, but this rate is much, much higher than typical rate we see in non-LDS patients with a cleft palate. So there's significantly higher incidence of tympanic membrane perforation after ear tube placement in LDS patients. We think this might be due to if there's a impaired TGF signaling pathway, it may affect the normal tympanic membrane repair pathway. And so clinically, it's important for us to think about whether ear tubes should be done or not in LDS patients, as there's high risk for tympanic membrane perforations. And then also, if one were to proceed with the surgery, perhaps we should consider using more sturdier graft materials such as a cartilage to get a better outcome. So when you have a chronic eustachian tube dysfunctions, this also can lead to a retraction pocket and a cholesteatoma, as shown in this picture here. It basically refers to a accumulation of wax or squamous debris within the retraction pocket, and this resulted in chronic ear drainage, infection, and hearing loss, and often require surgery. So in our cohort, there was one middle ear cholesteatoma in LDS1, 2 in LDS2, and there was also ear canal cholesteatoma in LDS3. So it's important for a patient with LDS who has a chronic eustachian tube dysfunction to get a careful ear examination under the microscope to make sure they don't have a cholesteatoma in your ear. Okay, so next, Dr. Christensen will go over the degree and types of hearing loss that we saw in each subgroups within LDS.
Thanks. I'm not sure why the slides keep advancing like that. We're not touching them, but just bear with us when it happens. It's odd. It might be the table jiggling. So I'm going to talk about the incidence of hearing loss by LDS type, but here's a quick snapshot of what we're looking at. This is by individual. So in LDS type 1, there were 24 people and 25% had a hearing loss. In type 2, there were 25 people in our cohort and 32% had a hearing loss. In type 3, there were 11 people in our cohort, 36% had hearing loss. In type 4, there were 10 people and 40% had hearing loss. And in type 5, there were 11 people and 9% had hearing loss. So now I'll do a deep dive into each of the types with more information. And this time you'll see that same pie chart, but you probably notice it's slightly different. And that's because for this section, I'm going to report on hearing loss by ear instead of by individual, because some people had hearing loss in both ears and some had hearing loss only in one ear. So I think this gives a more detailed view. We had 24 people, and the age range was 6 to 56 years old. Mean age was 22 years, with a standard deviation of 15 years, and the median age was 18 years. And there were 6 people in this group who had hearing loss. 5 had hearing loss bilaterally, meaning in both ears, and 1 had hearing loss unilaterally, just in one ear. So all told of 48 years, 11 years had hearing loss. The degree of hearing loss was mild in 27%, moderate in 43%, and severe in 27%. And the type of hearing loss was overwhelmingly conductive. 82% had a conductive hearing loss. One person had a mixed hearing loss, and one person's hearing loss type was unknown. And that's because of what I talked about earlier, that the hearing loss was at 8,000 hertz, 6 and 8,000, and we can't measure bone conduction from that frequency alone. In LDS type 2, there were 25 people, and 28% of ears had hearing loss. The age range was 4 to 65 years. Mean age was 25 years, standard deviation 17 years, and the median age was 18 years. And 8 people had hearing loss, 6 had it bilaterally in both ears, and 2 had it unilaterally. 14 ears out of 50 had hearing loss. And the degree of hearing loss was mild in 50% and moderate in 50%. And the type of hearing loss was, again, overwhelmingly conductive with 79%, while 2 people, 14%, had mixed hearing loss, and 1 person had an unknown high-frequency hearing loss. In LDS type 3, there were 11 individuals. The age range was 5 to 68. The mean age was 40 years with a standard deviation of 19 years, and the median age was 38 years, and 36% of ears had hearing loss. 4 people had hearing loss, and all of them had it bilaterally. So in total, 8 ears out of 22 had hearing loss. And again, like with the other one, type 2, the loss was split evenly, mild in 50% and moderate in 50%. And different from types 1 and 2, in type 3, the loss was overwhelmingly sensorineural. 88% had a sensorineural loss, and 1 person had an unknown loss. In type 4, there were 10 people. The age range was 23 to 61. The mean age was 42 years, standard deviation 14 years, and the median age was 41 years. 30% of ears had hearing loss, and 4 individuals total had hearing loss, with 2 people having a bilateral loss and 2 having a unilateral loss. So 6 out of 20 ears had hearing loss in type 4. And the degree of hearing loss was largely mild at 67%, but 33% of people had a moderate loss. And again, like with type 3, the overwhelming type of hearing loss was sensorineural at 83%, with 1 person having a mixed hearing loss. And finally, type 5, there were 11 individuals. 9% of ears had a hearing loss. The age range was 3 to 62 years. The mean age was 32 years, with a standard deviation of 20 years and a median age of 34 years. There was only 1 person with hearing loss, but it was bilateral in both ears. So out of 22 ears, 2 had hearing loss. And that hearing loss was mild in both ears, and it was also sensorineural in both ears. And then, as Jeff mentioned before, we couldn't analyze type 6 because we only had 1 individual, and hearing was normal. So we noticed that in our group, in types 3, 4, and 5, the age skewed older, and it made us wonder if any of the hearing loss we're looking at could be related to age as opposed to LDS. I'm going to walk you through this figure. This is, well, I'll start with the dots. All of the red dots indicate hearing threshold, the softest sound someone is able to hear at a single frequency. In this case, we're looking only at 8,000 hertz, which you'll remember is the highest frequency in the speech pure tones that we measure. So this shows you their threshold, red for the right ear, and blue dots are thresholds in the left ear. And on the side is the degree of hearing loss, and it's just like the audiogram, except it's flipped. So now normal hearing is on the bottom, and the degree of hearing loss increases from mild to moderate to severe to profound as we go up. Normal hearing is anything on this green line or below it, and across the bottom of the graph or the figure are ages. So for example, if we take this blue dot right here, this person had a 75 dB threshold, that's in the severe range, and they were probably 22 years old. So that's how you read this chart. And as you get older, this person right here had in their right ear, they had, it looks like a 65 dB threshold, and they were probably about 55 years old. So I'm going to add these lines to the chart. These are the 5th, 50th, and 95th percentiles for age-related hearing loss. You can see that age-related hearing loss increases as we age, obviously, and this is just the norms for women. Anyone above the green line, but within these black lines, could have a loss related to age as opposed to Loeys-Dietz. And we can see the same with the men. Men have different norms for age-related hearing loss than women. They tend to have more hearing loss as they age, but it's the same idea. Any of these triangles, red for right ear, blue for left ear, that are above the green line, but within these gray lines for men, that hearing loss could be age-related. And it looks like there's less men here, but it's because a lot of their thresholds are lying exactly on top of each other, so you can't see the extent of them. So this is that graph for all women in our group, not separated by type. And the 500 hertz is the lowest frequency, and 1,000 and 2,000 are the mid frequencies. And you can see there's very little age-related hearing loss at these frequencies. But as we get to the high frequencies, 4,000 and 8,000, there is a little more loss, which we can't definitively attribute to Loeys-Dietz or to age. It could be either one, but it's something to keep in mind that age is a possibility. And here is the same graph with men in our group. And I'll point out again that this area where it has the potential to be age-related, the majority of it is occurring in the men, 2,000, 4,000, and 5,000 hertz. And the last part I was going to talk about is longitudinal data. We've had 9 people who have come back for additional testing besides their first baseline test. You can see in column 1 the LDS type that they had. In column 2 is the number of visits, and then the span of time between the tests. And the majority of the time between tests was 5 to 7 years. And over that time, hearing has largely been stable. And the 2 exceptions is the one with LDS type 2 had a shift in hearing that was related to a cholesteatoma. And another person with LDS type 2 had a shift in one ear, but of unknown etiology. It wasn't clear what caused it. Everyone else has been stable so far.
Okay. Yeah. So so people to try to look at why they have a conductive hearing loss and severe hearing loss. So if you try to just summarize data, for a type 1 and 2, most of the people that had tympanic membrane perforation and developing conductive hearing loss, because when sound is transmitting through the ear canal, eardrum, that little oscular chain, that when you have a tympanic membrane perforation, the sound energy cannot be directly transferred to the inner ear, so that has conductive hearing loss. But there are also people that had a conductive hearing loss even though they didn't have a tympanic membrane perforation, and we think that their perforation into their hearing loss is due to perhaps there is a scar tissue within the oscular chain. We also seen in those who had the tympanoplasty or eardrum repair or had a surgery for cholesteatoma, so their oscular chain and the eardrums are probably not perfectly normal. And there's also a possibility that, like the other collagen disease, some of the joints within the ossicular chain also may be affected, so that sound cannot be efficiently transmitted to the inner ear, resulting in conductive hearing loss. And in LDS2, there was an older patient had a combination of conductive sensory hearing loss, as Dr. Julie Christensen mentioned, that it also could be related to the early hearing loss more than expected for age. When you look at the LDS 3, 4, and 5, all the patients with the 3 and 5 actually had sensory hearing loss, and then 4 had a combination of a sensory and conductive hearing loss, resulting in mixed hearing loss. And we think there's a possible that TGF signaling pathway, TGF beta signaling pathway, might be affecting inner ear function in the cochlea. It is well known that TGF beta signaling pathway is important for maintaining and repairing inner ear after infection, inflammation, or trauma. So if there is any dysfunction within the TGF beta pathway, it may result in early sensory hearing loss. So we're trying to look at other factors might be contributing to early hearing loss, like for example, maybe perhaps hypothermia related to aortic surgery. Perhaps it could be causing earlier hearing loss.
So in summary, hearing loss is a significant finding in people with Loeys-Dietz, about 38%, depending on the type. And people with Loeys-Dietz are more prone to ear infections and cholesteatoma due to eustachian tube dysfunction associated with palate anomaly. Conductive hearing loss and tympanic membrane or eardrum perforations were limited to LDS types 1 and 2, whereas sensory neural hearing loss was limited to LDS types 3 and possible 4 and 5. Non-healed tympanic perforations after ear tubes were more common than expected. Dr. Kim already talked about this, but the TGF beta pathway may be involved in the healing process. Indications for ear tube placement should be carefully considered. And if eardrum repair is considered, consider using sturdier grafts like cartilage. But this is also based on a very small number of individuals with LDS. And based on these observations, routine hearing and ear surveillance in LDS is recommended starting in children by the age of 2 years of age and at kindergarten entry, and every 3 to 4 years thereafter, or sooner if hearing loss is identified or there are hearing concerns or frequent ear infections. And this is true even when they've passed a newborn hearing screening. I'll just say that although a mild hearing loss could significantly impact an adult, it depends on the adult. With children, a mild hearing loss can be educationally significant and have an impact on their ability to learn language and to perform in school. And so it's important to really stay on top of even a mild hearing loss in children. And we just want to acknowledge our colleagues at the National Institutes of Health, including the National Institute of Allergy and Infectious Disease, who run the protocol. And a very special thank you to the 82 individuals with LDS and their families who volunteer their time to come to NIH to participate in this study. We wouldn't have this information if not for the commitment of the individuals and families who came. Oops. And that's it. Thank you for listening.
Thank you.
Stacy, I'm going to stop sharing our screen. Does that sound right to you?
Yeah, that's fine. I think that your presentation was really thorough because there are not a lot of questions in the Q&A, and every question that I kept coming up with, a moment later, you were answering it. So thank you. But I do have a question that I think several may be wondering, but particularly related to the to ear tubes. For individuals with Loeys-Dietz syndrome who may be advised to have ear tubes placed, What information would you say they should make sure they share with their healthcare providers to ensure safe and appropriate care?
Yeah, so I mean, I think this also depends on what LDS type that you have. 3 and 4, 5 and 6 is probably less likely to have problem a with the year two placement, but then type 1 and 2, who are often associated with cranial anomaly, may have issues with the palate and the eustachian tube resulted in middle ear fluid. So, but sometimes when you have a middle ear fluid, it doesn't always require ear tube placements, and so you might be able to observe for a little bit longer and then consider it. And then if there's issue with the hearing loss, you also look at the options about amplification with the hearing aids as well. But again, when you have a ear tube placement, discussion with your ear specialist or ENT specialist, then I think you have to look at the what the risk and benefit for having ear tube placement, because again, there seem to be higher incidence of ear tube tube causing tympanic membrane perforation.
Great, thank you. And then another question, I think that would really generally apply, but for patients themselves or for parents, what are some of the early signs of hearing changes that they should be aware of and that they shouldn't ignore?
Well, that's a really good question, and it's tough, especially if it's a mild hearing loss, because it's very hard to tell when someone's got a mild hearing loss. Um, some things to, of course, look for is if someone's saying what a lot, if they aren't responding to you, if they're across the room or their backs to you. Now, a lot of children will do that anyway, and it doesn't mean they have a hearing loss, but if you persistently notice something like that, it's definitely worth bringing your child in for a hearing test. If they're in a noisy setting and they don't seem to understand or follow what's going on compared to other people, especially young people, that's another indication. If they have a lot of ear infections, like Dr. Kim was saying, fluid can cause temporary hearing loss, but if you have it chronically for multiple months out of the year, it can be impactful. And an ear doctor could walk you through that if it comes to that point where you're trying to decide what to do about it. I think that a common thing in audiology is to say the first screener is the parent. And if a parent has hearing concerns, it doesn't take very much to bring someone in and get their hearing tested. It can be challenging when kids are little, but if you have a pediatric audiologist, they should be able to test your hearing. I mean, I don't fit hearing aids at the NIH, but in my former job at a different research hospital, I fit hearing aids on children who were 3 or 4 months old who we'd identified with hearing loss. So there are a lot of ways to test hearing to see what's going on. So I think that if you're regularly monitoring it, at 2 years, and then before they start kindergarten, but if you have concerns in between those points and you just bring them in for testing, you should be in good shape and covering all of your bases.
Thank you. There is a question here. The person asking is 66 and has LDS type 4. And they are wondering if you have any information on hearing loss and Chiari malformation, which we do see occurrences of in people with Loeys-Dietz syndrome. So curious if you have any insight on that.
Yeah, so most of the time, the Chiari malformation is when you have the bottom portion of the brain kind of herniating through the bottom of the skull base. And typically, it doesn't cause us a hearing loss, but if it's severe enough, actually, it could affect hearing. Or sometimes when Chiari malformation is severe, it could also causes increased pressure in brain called intracranial hypertension. Sometimes that can affect the hearing as well. But most of the time, Chiari malformation doesn't always cause some severe hearing loss.
Thank you. Another pretty more specific question. This is a parent explaining that their son has type 2 and was diagnosed with profound sensorineural hearing loss in his right ear at age 4. So he has type 2, is at age 4, and they now have a cochlear implant. They don't have the typical cranial markers, and the audiologist could not determine the cause, only saying that the causes of the majority of hearing loss cases is unknown. Do you think that LDS could be the culprit? How would you like to respond to that?
Yeah, so it's kind of tough question to answer, but based on our study, I think the sensory new hearing loss in LDS3 of that much hearing loss is kind of severe. Usually we expect them to see conductive hearing loss, maybe some sensory hearing loss. It's because I talked about how the TGF beta pathway can affect the maintenance of your function, but that significant profound hearing loss I think is atypical. But again, our cohort is so small. It's a disease, rare disease. I mean, there's always exception, and then also you have to think about that LDS is fairly rare disease. I mean, there are other causes that can cause unilateral sensory hearing loss. So you also have to think about that as well. But I guess the other question I have is that whether the patient had hearing loss since birth or something that the patient had developed over the child that developed hearing loss over time. I'm not sure.
We'll
But we'd
see.
be happy to discuss if you send us more information.
Okay. I will include my contact information. So if you have questions that we're not able to answer today, or that our team here has said they need a little more information for, you can certainly reach out to me. But there is another question here about what sort of medication is recommended for a 22-year-old who has LDS2 with bilateral perforation and mild conductive hearing loss. It sounds like they had a tympanoplasty. It was attempted and it failed. Should they talk to their team about considering another one?
Yeah, so I think that's kind of consistent with the few patients who had the surgery among the cohort that we saw at NIH. There are a few patients who underwent implantation and failed, and I think a testament to a few things. One is that maybe there is an issue with the repairing mechanism. So when we try to repair, maybe we should consider more sturdier a material like a cartilage graft, maybe will take better. And then the other thing is that you also need to think about like the eustachian tube, dysfunction. If there is a persistent eustachian tube dysfunction, sometimes it does the graft doesn't always to get taken and heal. So that's something to think about as well. And if just because you're tympanic perforation, it doesn't mean that you always have to patch them up either. If it's causing minimum hearing loss, you don't have to worry too much about it, except for water precaution, like when you go swimming. And then if you also have more than a slight mild hearing loss, then the hearing aid also might be an option for amplification as well. But we do see that higher incidence of perforation after tympanoplasty. I mean, we don't have that many patients who had this tympanoplasty surgery done, but there are a couple of patients I know had difficulty.
Thank you. I want to give a moment if there are any more questions. This is the time to ask as we are nearing the end. Or
Did
if,
I see?
yes, go ahead, Julie.
Did I see a thing pop up saying someone passed their newborn hearing screening and
Yes,
then
so the person
got
who
the
asked the
prescription
question
before?
before, yes, they passed the newborn test, but didn't pass the pre-K audiology screener. So they don't know when in that period of time, in between that period of time, the hearing loss may occur.
Yeah.
Was that just in one ear, or was that in both ears? Did it say? I wasn't. No.
I'm
Okay.
looking.
Yeah.
Just
But
one.
she's also responding
Yeah.
quickly, just one ear.
Yeah, which is part of why it probably wasn't discovered till kindergarten. That would be a very hard loss to figure out, especially now that kids don't use telephones like they used to.
Yeah. Yeah. I mean, but sometimes, like we have seen cases where people have a progressive unilateral hearing loss, like for example, they could have a very mild form of CMV, congenital infection can do that as well. So I don't know whether they test the child for CMV at birth, but most likely not because I guess he passed a newborn hearing screen.
That's cytomegalovirus, and that is
Yeah.
a common cause of hearing loss in people that don't have anything else going on. And like Dr. Kim said, people, LDS is so rare, there could be other things causing the hearing loss separate. And a lot, a family history or other things like CMV is a common one as well.
Yeah. Well, but I think it's also it's important that we have to be open to a case like that. I mean, maybe there is a sort of LDS, we just haven't really found it yet. So obviously we're going to be very interested in continuing to study people with LDS, so that we have a better characteristic about their hearing problems.
Yeah.
Well, that's a great plug for encouraging folks to volunteer to participate in the study. It is open to those in the US. I know we had a few folks here joining us internationally, but this particular study is only open to those in the US. And if you are interested in learning more about getting involved in that, you can find information at loeys-dietz.org/research, and I'll include that in the chat here. And I see another question came in through the Q&A from Allison. Oh my gosh, is pulsatile tinnitus bone or conduction issue, and is it seen commonly with LDS?
That's a good question. We haven't really specifically asked the question, but very few people kind of volunteer about that. But when you have pulsatile tinnitus, it could be due to two main causes. One could be ear problem, but as you know, not many LDS patients do have vascular tortuosity and other vascular wall abnormality, and that can kind of create what we call the murmur, and that can radiate to the ear. So that might be one cause of it. So, obviously, people who have pulsatile tinnitus should get more tests done looking for like any aneurysm or dissection or the wall abnormalities. And another possibility is that sometimes if there is issue with the bone malformation of the ear, sometimes it can cause a pulsatile tinnitus. But I have to say that we haven't really seen a lot of people have complained about pulsatile tinnitus.
Wonderful. Thank you so much. Thank you for sharing your expertise and insights with us today. Thank you to everybody who joined us. I shared the link on how to participate in the chat. It's a clickable link. So if you want to click that, it'll open in a new tab and you can explore different opportunities. I also want to share a quick save the date for our global virtual conference that's hosted by the Marfan Foundation. It will be online June 15th through 18th, and you'll hear from other expert providers, and you'll get updates on different research projects that are happening related to Loeys-Dietz and related conditions. So keep an eye out in your emails for more information about how to register. That should be available fairly soon. And a reminder that we recorded today's session so that you can access this information at a later date. You can find it at our on our YouTube channel. I also want to share my contact information. If you do end up participating in the study at the NIH, I would love to see you in person. I live nearby. Please feel free to send me an email to connect at swatson@loeys-dietz.org. And it's just great to be able to build community with others. And the foundation has a lot of ways for you to do that, not just at that virtual conference, but we do a lot of in-person events around the country, walks for victory that we liken to family picnics, which are really wonderful. And you can find out more at loeys-dietz.org. Again, please join me in thanking Jeff and Julie for their time, for their expertise. And we are just so deeply appreciative. Thank you.
Thank you, Stacy, for all that you've done to bring awareness to